Sharath. Fundus fluorescent angiography, with the advent of multimodal imaging, our age-old FFA is sometimes underrated. But FFA has got very important clinical uses in diabetic macular edema. Dr. Parvathy will be elaborating on the relevance of FFA in the current scenario.
Good morning, all. Today I will be talking the relevance of fundus fluorescent angiography in diabetic macular edema management. So, FA is a diagnostic procedure where series of photographs of both eyes are taken after injecting sodium fluorescein intravenously. And as we know, it has various phases like the choroidal phase, arterial phase, early AV phase, late AV phase, recirculation, and late phases. Does FFA still have a role in diabetic retinopathy and DME management? Or can we just treat based on the OCT or OCTA and clinical correlation alone? The answer is yes. FFA still has its own role in diabetic macular edema management, and it is considered in clinical practice for two reasons that might be difficult to obtain with any other imaging modality, that is ischemia and leakage. So, the role of FFA include to study the perfusion status of macula, to characterize the type of diabetic macular edema diagnosed on ophthalmoscopy and OCT, like whether it is having a focal or diffuse edema, whether the edema is perfused or non-perfused, and to investigate in a diabetic patient the vision loss which is incompletely explained by other modalities, that is to rule out macular ischemia. So, saying about macular ischemia, we should know about the normal foveal avascular zone. That is a hypofluorescent area seen in the fovea, and it is a capillary free zone of 350 to 500 microns in diameter present at the fovea, and this hypofluorescence is due to absence of blood vessels and the presence of xanthophyll pigments, and this is visualized in the late venous phase around 25 to 30 seconds of the fluorescein angiogram. So, in order to rule out macular ischemia, we have to look at the size of the foveal avascular zone, the morphology of the foveal avascular zone. The foveal avascular zone can be enlarged or distorted, and saying about the enlargement of foveal avascular zone, there is not a definitive cutoff for this enlargement, but always if it is more than 1000 microns, it is considered abnormal. We have to always compare it with the other eye. Normally it is around 500 microns in size, and we have to always check for the margins of the foveal avascular zone. If whether the margins are continuous or there is any break in the capillary network of the FAZ. And here we can see a case of macular ischemia, and the question is whether there is no role for macular laser in this type of ischemic maculopathy. Whether anti-VEGF and steroids can help, that is questionable. And can OCTA replace FA? Actually, OCTA is a very good tool to identify ischemia. But in case of diabetic macular edema, due to the edema and fluid, there will be errors occurring in the OCTA segmentation, and also the capillary density will be falsely reduced in cases of edema. So, FFA stands better than OCTA in diagnosing macular ischemia. Then we have the second role of FFA is to identify the type of maculopathy. To identify the type of maculopathy, that is whether it is a focal maculopathy caused due to microaneurysm leaking fluid into the retina, or if it is a diffuse maculopathy due to dilated retinal capillaries, or whether it is mixed, that is a combination of focal and diffuse. Here, focal leak, we can see in the early phases multiple microaneurysms are here, and in the late phases these microaneurysms are leaking, and if the majority of the leak, more than 2/3 of the leak is caused around the microaneurysm, it can be considered as a focal leak, and these focal leaks can be treated by focal laser if it is non-center involving, and FFA can be used, these images can be used to guide the photocoagulation of these leaky microaneurysms, and direct laser treatment can be applied to all focal points of leakage located between 500 to 3000 micron of foveal avascular zone. And if we are planning laser, we have to look at the relation of the leaky microaneurysm to the foveal avascular zone, and we have to avoid laser if it is within 500 microns of foveal avascular zone. Here we can see multiple microaneurysms. in the early phase, and in late phase this microaneurysm, it is not leaking, and these aneurysms are leaking, and these are away from the foveolar vascular zone, these are also leaking. And so the first one, since it is not leaking, there is no need for any laser treatment. And for the second one, it is within the 500 micron of foveolar vascular zone, so we have to avoid laser. And in the third one, we can apply focal laser if needed. Then coming to diffuse leak, it is characterized by dilated capillaries which leak the fluorescent dye in the late phases, and according to ETDRS, the grid technique of laser can be applied to treat these diffuse leakages. And nowadays, if it is a DME center involving, we will treat it with anti-VEGF or steroids. Then this FFA can also used to assess the adequacy of macular laser treatment and the reappearance of edema, whether the leakage is caused by any new aneurysms. And another role of this FFA is in identifying pseudophakic CMA, that is in a pseudophakic patient with macular edema, cystoid macular edema, we have to always differentiate it from the whether it is caused by Irving-Gass syndrome or diabetic CMA. And in FFA, if it is Irving-Gass, we will get late stage petalloid edema, and the disc will be leaking in the late stages. And in diabetic CMA, there won't be disc staining unless there is a neovascularization of disc. Both of this will be having petalloid edema on FA, but based on the disc finding, we can classify, and treatment can be done accordingly. So to conclude, FFA is important at baseline to identify ischemia, whether the edema is focal or diffuse. FFA helps to plan the treatment, what to treat and what not to treat, and it has a role in pseudophakic CME, and FFA helps in assessing adequacy of laser treatment. That's it. Thank you.